Hello everyone, welcome back to Karan Academy. My name is Karan and I hope you are all doing super well. Today we're going to be continuing on our lecture series. We first spoke on ECGs and today we're going to be talking about arrhythmias. Now arrhythmias are a very high yield concept when it comes to your exams as well as things you'll see on the ward. So it's really important to combine what we talked about in our interpreting ECGs lecture and now understanding a bit about how they carry over and then having a good understanding of the principles of managing these different arrhythmias. Alrighty, so starting off nice and easy, a really good system we can use to classify our arrhythmias is based on the fact that are they tachycardic or bradycardic. The cutoffs we use are 60 and 100 respectively. So bradyarrhythmias are arrhythmias with a heart rate of less than 60, tachya above 100. Another way we can, once we know that a person is tachycardic and potentially has an arrhythmia, a really good tool we can use is assessing the regularity of the heart rate and whether this is a regular tachyarrhythmia or an irregular tachyarrhythmia. Now, each person can have their own system of classifying these arrhythmias, but this is one that I found to be particularly helpful in understanding the key concepts and the key types. Let's start with bradyarrhythmias, and basically they are arrhythmias with a slow heart rate. How do they present? As you can imagine, with a slow heart rate, they can present with symptoms of reduced cardiac output. These include things like syncope, pre-syncope, feeling dizzy, feeling short of breath, and they can often present with palpitations if the heart rate is irregular as well. The main ones that we will talk about today include sinus bradycardia, AV heart blocks, and bundled branch blocks. I talked about AV blocks briefly in the ECG video, which you can find a link to somewhere in this corner. And we basically have three different types. We have first degree heart blocks, second and third degree heart blocks. And these are also in ascending order of severity. First degree heart blocks are often non-pathological. We have a slight increase in the PR interval, which is consistent throughout each cycle, does not change, and often is asymptomatic. It can be caused secondary to coronary artery disease as well as electrolyte imbalances, but in most cases it is idiopathic and does not require treatment. With second degree heart blocks, we have two kinds, Mobitz 1 and Mobitz 2. Mobitz 1 is also called Wenckebach. In Mobitz type 1, we have the PR interval, which increases gradually with each beat. So we have a gradual prolongation followed by a drop where we don't have a QRS complex. And this can be very clearly seen here, where the PR interval is increasing, drop in the QRS. So we have a P wave with no QRS, and then the same thing repeats. Versus with the type 2, Mobitz type 2 second degree heart block, we have a consistently increased PR interval, and then we have every second or third beat or QRS complex being dropped. So there isn't a gradual prolongation, it's just you are skipping every second or third QRS complex. And this can be seen in figure 2.4 right here. Now, third degree heart blocks are pretty nasty, and they often are quite symptomatic and do require treatment. What basically is going on with third degree heart blocks is you've lost all connections between the atria and the ventricles, grossly speaking, which is why we have our P waves, which contract, which are completely independent of the QRS complexes. As you can see in figure 2.7, the P waves are pretty regular. We have 1 here, 2, 3, 4, 5, and as you can see with the arrows, they're pretty regular, contracting at a bit over 150 beats per minute, the P waves, that is. However, the QRS complexes are quite sparse, and as you can see, they're not linked to the P waves in any way. When we have such a complete disjunction between the P waves and the QRS complexes, this would be a third degree heart block. In terms of general principles, if a patient is asymptomatic, they're often monitored quite conservatively, and we only treat their complications if they do have any. However, if they're symptomatic and are stable, we might admit them, monitor them. And if they're unstable, we might consider more aggressive interventions like atropine and even temporary pacing. Or temporary transcutaneous pacing or percutaneous pacing, where what we basically do is insert a small device that basically tells the heart to contract in rhythm with the P waves. So we have a degree of coordination between the atria and the ventricles, and they may then require a permanent implantable device. A good way I like to think about AV blocks is a visual representation of Raymond Holt. As you can see, third-degree heart blocks, not very fun. Moving on to bundled branch blocks. In terms of the electric conductivity system of the heart, we know we have the sinoatrial node in the right atrium. We then have the AV node in the interventricular septum, which then gives off the bundle of His, which then divides into the right branch and the left branch. If you have a block in the conduction of this would be called a bundle branch block. Now, as you can imagine, you can have a block to the left or the right. A slight complexity is that the left branch also consists of two subdivisions called fascicles, where you have an anterior fascicle and a posterior fascicle. So here we have the left anterior fascicle and the left posterior fascicle. You can block them as well. So depending on how many of the branches have been blocked, you can either classify them as unifascicular blocks, where you have either blocked the entire right bundle or one of the two fascicles. It can be a bifascicular, commonly a right bundle branch block and the left anterior fascicle, or you can have a trifascicular block, which does tend to be quite symptomatic and can be involving and does involve all three of the branches. A few other things that are worthwhile knowing include Sinus Syndrome, which is an issue arising at the level of the SA node, commonly caused by fibrosis. As you can imagine, fibrosis interferes with the electric activity of the cardiac myocytes, but it can also be caused due to medications like beta blockers and calcium channel blockers that affect the contractility of the heart. This is managed by either removing the stimulant, if there is any that we can identify, or if we can't identify one, we treat them just as we treat AV blocks. So if they're symptomatic, we treat them. If they aren't, then we manage them conservatively. We also have sinoatrial arrests, where basically the SA node stops creating impulses for 3 to 30 seconds. It's quite common, and I'm sure some of you have experienced this, where you almost feel a flutter or you feel as if your heart skipped a beat, so to speak. You then also have tachycardia bradycardia syndrome, which is a subtype of 6 sinus syndrome, and it's quite similar in etiology. In terms of how it presents, it can present with palpitations or symptoms of bradycardias like dyspnea and syncope, presyncope, and so forth. Moving on to tachyarrhythmias, you'll talk about atrial tachyarrhythmias first and then talk about ventricular tachyarrhythmias. So atrial tachyarrhythmias are where you have a heart rate above 100. What makes them atrial versus ventricular is what the origin of this issue is. If the increased frequency of firing is originating in the atrium, then it's an atrial tachy versus a ventricular tachy. How do we know which or where the origin is? Well, the QRS complex is where the money's at. If the QRS complex is narrow, which means that it's less than 0.12 seconds, it usually indicates that the issue is above the level of the ventricles. I discussed this in the lecture on ECGs, but if the issue is at the level of the ventricles, and as you can imagine, the ventricles themselves don't have a vast electric network. If you have an ectopic beat that's being generated in the ventricles, it would have to travel through the myocytes, which, as you can imagine, are not super fast at conducting nervous impulses, which is why if the tachyarrhythmia is ventricular in origin, it tends to last, the QRS complex tends to last longer because of that slow conductivity through the cardiac myocytes. How do they present? They present with, again, they might have palpitations, syncope, presyncope, or even chest pain. Now, as you can, if you noticed, these symptoms are quite similar to those of a bradyarrhythmia. And you might be asking yourself, well, Karan, how can I guess, tell the difference between the two? Firstly, you need to realize that the reason they get syncope or presyncope or shortness of breath is because of reduced cardiac output. Now, it's fairly straightforward why that's the case in bradyarrhythmias, but with tachyarrhythmias, often if your heart is contracting too fast, you don't have enough time for the ventricles to fill up adequately. So you can also end up with a reduced cardiac output system. Furthermore, if you have a heart that's contracting very fast and requires a lot of blood and oxygen, and your vasculature cannot cope fast enough, you can often end up with chest pain. or anginal chest pain. And you can also have dizziness, sweatiness, and be pale. And those are all fitting in with symptoms of excessive cardiac demand. The tachyarrhythmias that you need to know about include sinus tachycardia, SVTs or supraventricular tachycardia, atrial fibrillation, and atrial flutter. So let's go through these. A sinus tachycardia just means that you are tachycardic with a sinus rhythm, right? It doesn't tell us whether the issue is pathological or not. In most cases, it is non-pathological, but you can also obviously have some pathological causes. These pathological causes can be either at the level of the heart or elsewhere. For example, if you have a fever, if you have hypothyroidism or infections or hypotension or PE, all of these causes would result in a compensatory tachycardia. But obviously, the issue is not at the level of the heart itself. This can also be normal or induced by certain medications. And the way we treat this is reverse the stimulant if possible. And if not, we can use agents to slow the heart, like beta blockers like metoprolol or calcium channel blockers. Now, atrial fibrillation is a really big condition that is very common. Most of you will see this on the wards, and you need to know this one inside out. So atrial fibrillation is a supraventricular tachyarrhythmia that's characterized by improper atrial contractions and irregular ventricular responses. What this basically means is that instead of having a nice conduction system where you have one impulse at the SA going to the AV, going to the ventricles, you have something in the atria that's causing misfirings where you have a whole bunch of irregular, sporadic impulses being generated. And as you can imagine, some of these impulses would slip through the AV, some wouldn't, and you end up with a very irregular ventricular contraction. Therefore, the most common way AFib is described is atrial fibrillation with an irregular ventricular response. You can classify AFib in a few ways. Firstly, from a clinical acute setting perspective, are they hemodynamically stable? Secondly, in terms of chronicity, how long has this particular episode been going on for? Is this the first presentation? Has this been going on for less than 7 days, more than 7 days, or is this permanent? And thirdly, and we'll get to why this particular section is important, but is there a valvular involvement? And when we say valvular involvement, all I want to know is, are there any issues at the level of the valve? This doesn't necessarily mean that they should have a valvular heart defect. Obviously, any coexistent issue like a stenosis or regurgitation would mean that there is valvular involvement, but also have they had any operations to the valve? Do they have an artificial heart valve perhaps? And this is really important because it plays a key role in anticoagulation for atrial fibrillation. And we'll talk about this in a second. For AF, it's important to remember our cardiovascular risk factors screen that I've talked about in our third lecture. And for AF specifically, these are the risk factors, and a good mnemonic for them is parasite. I won't go through the mnemonic itself, it's pretty self-explanatory, but it's also important to remember that 15% of patients do not have any of these risk factors. So it can happen without an obvious cause. I briefly talked about the pathophysiology, but one important bit that's important to know is that these irregular impulses often originate near the entry points of the pulmonary veins. Now, this is important because a lot of the new procedures for atrial fibrillation include ablative surgeries, where we go and use an ablative device to basically ablate or kill certain sections of cardiac myocytes that might be arrhythmogenic, that might have an arrhythmogenic focus. Apart from that, AFib can obviously be made worse by any coexistent condition like thyroid disease or sepsis. And you can also have accessory pathways, which are abnormal pathways between the atria and the ventricles that usually should not exist. And we'll talk about them in a second. The one I've mentioned here, WPW, stands for Wolff-Parkinson-White, which is an important one to know about. So a summary of progression would be, I guess, in terms of how long do the episodes usually last for, They often start with paroxysmal, moving on to persistent and eventually permanent. A good point to know is that in terms of managing AFib, we have three important things we like to talk about, and that's on our next slide. So most cases of AFib are completely asymptomatic. And that's important because AFib presents a certain level of complications, stroke risks, as well as other hemodynamic complications. And if the patient does not have any symptoms, it's very hard for this to be picked up. So the irregular contraction itself can cause palpitations or chest pain. If their AFib is persistent, permanent, or they are otherwise frail, they may present with signs of hemodynamic compromise. So they might present with syncope and falls, shortness of breath, chest pain, fatigue, and acute pulmonary edema if they have a superimposed congestive heart failure picture. And lastly, systemic clots is really, really important because the heart is contracting so irregularly that abnormal blood flow can be prothrombotic and can cause abnormal clot formation, which is really important, which is why we try to anticoagulate most patients with AF. And we'll talk about that soon. So ECG is king. And when we look at an ECG, the one thing we look for AFib in particular are the P waves, because we know that P waves represent atrial depolarization. So if you have an issue with irregular firing at the atria, you would not see nice regular P waves. And that's exactly what you see here. You don't see any P waves, and you see completely erratic Chiorus complexes, which have no rate, rhythm, and are not regular. So this is an irregularly irregular ECG with no P waves, and that's quite typical of AFib. You also like to order thyroid function tests because hypothyroidism can be a predisposing factor. In terms of investigate and in terms of other imaging you might consider, you might do an echo to assess valvular function, their ejection fraction, and also check for any valvular defects. A chest x-ray if you suspect that they might have acute pulmonary edema, and you might also do a Holter monitor if you think that this person might have AFib, but you didn't pick it up during your, let's say, 10-minute consultation with them. So by assessing and taking a 24-hour ECG, you're more likely to pick up on these episodes. In terms of treatment, there are three pillars of AFib treatment. We want to control their rate, their rhythm, and manage their stroke risk. So what factors do we look at? So firstly, does the person have rapid AF? Their age, chronicity, their clotting risk, bleeding risk, and so forth. So the question arises, Karan, what patients do we manage with controlling their rate? What patients do we control their rhythm? Do we do both? And when do we anticoagulate? So the decision to control the rate versus rhythm is quite subjective and varies from physician to physician. However, certain factors that might lead you to be more likely to opt for a rate control measure include if they have rapid AF and if they're symptomatic. Factors that are against rate control, if the person's young, if they're pregnant, if there's certain contraindications to rate control medications, or if they generally require a high heart rate. Let's say you have a 20-something-year-old athlete. It is very unlikely that you would choose rate control because as a high-performance athlete, they probably need to be tachycardic at times, right? And that's quite normal for them. So rate control might not be optimal. If we do choose to manage their rate, we might opt for beta blockers or calcium shunt blockers. We can also perform a surgery called AV nodal ablation. That's not very commonly done. Rhythm control, if they are young, if they're pregnant, and if they've had poor control with rate management, we might then consider rhythm. In terms of pharmacological management, we have three main drug options. SAF is a good acronym. So the first one's amiodarone. So amiodarone is really effective, but can cause issues with the thyroid as well as pulmonary fibrosis. So if someone has a coexisting thyroid issue, we try not to use amiodarone. Sotalol is a beta blocker with a type 3 antiarrhythmic properties, and we don't use it if the patient has any form of chronic kidney disease, and it can also cause long QT syndrome. That's one thing to be aware of. If you have a patient who has a predisposition for hypokalemia, calcemia, magnesemia, which we know can cause long QT syndrome, it's likely that we'll try to avoid sotalol in those patients. Flecainide is a very safe medication. However, we don't use it if we suspect that the cause of their AF is structural. What I mean by structural is, have they had a past myocardial infarction that might have caused fibrosis and actual damage to the heart wall? That will be structural AF. Or if they have a history of ischemic heart disease, we try to not use flecainide. In that case, we might opt for something like amiodarone. Surgical radioablation is also used, and that goes back to ablating certain arrhythmogenic foci, usually near the pulmonary veins. Lastly, we can also opt for electric cardioversion, and this is often done in unstable AF. If the patient comes in, they're symptomatic and hemodynamically unstable. However, we need to ensure that we anticoagulate them so that they don't have or reduce their risk of having a thrombus formation that eventually causes a stroke. So this is quite common and is a bit confusing. So going into anticoagulation with cardioversion, when do we need to anticoagulate them? When can we cardiovert them and when we can't? So as a rule of thumb, if a patient is unstable, your risk of hemodynamic complications are way more than the possibility of a stroke. So therefore, we would cardiovert them and then give them anticoagulation. If they've had AF or symptoms for less than 48 hours and are otherwise stable, we provide anticoagulation before cardioversion only if they have a higher risk for thromboembolic events. And this is based on the CHADVAS score that I'll mention on the next slide. However, if their AF has been for longer than 48 hours, it is likely that they might have a thrombus formation in one of the ventricles already, which is why we want to anticoagulate them either with a DOAC or warfarin. Physicians can use either, but DOACs are usually easier to use. And the usual timeline is 4 weeks. And then we want to give them the same medication for 4 weeks after the episode. So as you can imagine, it's quite a strenuous process of 8 weeks of medications for a single cardioversion episode. We can also use a transesophageal echo to visualize the atria to look for any suspected clots. It's important that you talk about a transesophageal, not a transthoracic, because of the positioning of the heart, the atria usually lie more posterior, which is why a transesophageal echo is much better at visualizing the atria compared to a transthoracic. In terms of anticoagulation, we use the CHADVAS score, and I would highly recommend that you learn the components of the CHADVAS score and how to calculate the score. We basically have to balance what their risk of having a clot is, which is through the CHADVAS score, and what their risk of having a bleed is or a hemorrhage is, and that's using the HAS-BLED score. I wouldn't recommend learning the HAS-BLED score, but the CHADVAS is definitely important. If a patient has a CHADVAS score of more than 2 for males or 3 for females, we recommend anticoagulation, which can be either with a DOAC or warfarin. Now, this decision usually depends on whether they have any valvular involvement. If a patient has valvular involvement, which means they have any form of a valvular heart defect, stenosis, regurg, or have had a valve replacement, we would go for warfarin. Versus, for all other cases, we usually go for DOACs. The issue with the warfarin is that it requires regular INR monitoring. And that's a weekly blood test that you need to have, which can often be quite, which may often be unsuitable for older patients or patients with poor access to medical resources, versus DOACs are usually easier. Now, the difference is not based on an actual difference in the properties of the drugs, but just various RCTs have found one to be superior to the other in certain circumstances. For people with a score of less than 2 or 3, the use of aspirin is subjective and has a questionable role. You can give aspirin. However, other antiplatelet medications are advised against. Moving on to atrial flutter. So atrial flutter similarly is a type of supraventricular tachycardia. And instead of having just ectopics, we end up with a re-entry circuit loop. So think of it like this. You have one ectopic foci. It generates an electric impulse. that spreads, and eventually it comes back to that same foci, and it ends up creating a vicious cycle of re-entry circuit loops. And every now and then, those electric impulses also travel to the AV node and to the rest of the heart. So it causes really, really high atrial rates with a correspondingly high ventricular rate. Now, depending on the ventricular rate, we can classify them as a few types. So if you have a ventricular rate of 1 to 1, that's quite deadly, as you can imagine, versus 2 to 1 versus 3 to 1. What this basically means is that a 1 to 1 ratio means that you have one ventricular contraction for every atrial contraction, versus 2 to 1 means you have one ventricular for every 2 atrial, and so forth. In atrial flutter, the atrial rate usually sits about 300. And as you can imagine, that's quite high. And you see this typical jagged tooth appearance. In terms of the management, you can try to solve this conservatively by employing vagal maneuvers like with the Valsalva, carotid massage, or cold water. However, if they're hemodynamically unstable, you again go for DC cardioversion. We may again consider the same principles of treatment as with AFib, so rate control, rhythm control, and anticoagulation. Now, supraventricular tachycardias, as the name suggests, are tachycardias originating above the ventricles. But then the question arises, Karan, did we just talk about atrial fibrillation and atrial flutter, which technically also are SVTs? And you'd be absolutely right in terms of saying that they technically are SVTs. However, the term SVT is usually reserved for some special cases, and two specific ones are AVRT and AVNRT. Those stand for atrioventricular nodal reentry tachycardia and atrioventricular reentry tachycardia. These are both very simple to understand if you just take a moment to understand the pathophysiology of what's happening behind the scenes. Once you visualize this, I promise you, you will not forget this. So let's start with what is the basic issue. So breaking it down, atrioventricular, so between the atria and the ventricle, you have a re-entry loop at the level of the node, and it's causing a tachycardia. So you have a re-entry circuit that has been set up in the AV node, very similar to the re-entry circuit I described with atrial flutter, but this time it's in the AV node, right? How does that happen? Because we talked about they're having, I guess, rhythmogenic foci or these abnormal myocytes, but what's going on in the AV node? So in the AV node, you have two different pathways. You have an alpha pathway and a beta pathway. The beta pathway tends to be a fast contraction versus the alpha pathway is a slow contraction. What usually happens is that the impulse travels down the slow pathway. So they come up from so you have the impulse coming up from the atria, right? The fast pathway contracts, sends it down. However, it takes a long refractory period to be able to contract again. What it means is that once it contracts, it's not going to be able to contract for a while. So by the time this contracts, this transmits the impulse, you have the alpha pathway slowly moving the electric impulse down. By the time it's reached the ventricles through the alpha pathway, the beta pathway is still in the refractory period, which means that it's not going to go up, right? However, if you have suddenly a wild ectopic that's generated somewhere in the alpha pathway, that is not when the beta pathway is in refractory period, you can have a situation where it transmits to the ventricles, but also up through the beta pathway. And now you have basically a circuit of electric impulses traveling between the alpha and the beta pathway. And every now and then they would let off discharges into the ventricles. And that's basically an atrioventricular nodal reentry tachycardia because it's re-entering the AV node. If the patient is hemodynamically unstable, you use IV adenosine or DC cardioversion. And if they're stable, you go for vagal maneuvers like the Valsalva, carotid massage, or cold water, as I mentioned. If they are chronically in SVT, you might consider beta blockers, calcium channel blockers, or ablative surgery to basically burn out or ablate the path that's one of the paths to prevent that from happening. An atrioventricular reentry tachycardia is very, very similar. However, the loop is much bigger. Instead of the loop just being here in the AV node, it's a bit bigger, and it's because of this accessory pathway between the two. So what usually happens is you have the SA node going down to the AV, going down to the bundle of His, and then Purkinje fibers, right? Usually, these paths are blocked off and do not conduct electricity, which is why the electric impulses stop here. However, if you have an accessory pathway, which is abnormal, for example, in the condition called Wolff-Parkinson-White, where this accessory pathway is called the bundle of Kent, what can happen is you have the SA node to the AV, AV to the bundle of His to the Purkinjes, and then it goes up and passes through the bundle of Kent, enters back in, and that basically sets up the exact same thing, very similar to what we discussed here. Oops. Yes, very similar to what we discussed here. So we notice a short PR interval as well as a specific kind of wave called a delta wave. And that can be seen right here, where we have a shorter PR complex and an upsloping delta wave. And yeah, so this is just what I've described again. And here is another diagram showing the same thing. And this is a representation of Wolff-Parkinson-White. As you can see, you have a shortened PR interval and you have these delta waves, which are these upsloping waves. Moving on to ventricular tachycardias or tachyarrhythmias. They're similar to atrial tachys, but are worse. So most of these are your kind of worst nightmare kind of cardiology picture. The QRS is wide, as I described earlier, and they present pretty similarly, but maybe worse in severity. The tachyarrhythmias, it's a typo there. Tachyarrhythmias, you need to know, include ventricular tachycardia and ventricular fibrillation, and the specific one called Torsades de Pons. A ventricular tachycardia usually involves 3 or more ectopics with a rate above 140. That's commonly seen. Causes include structural defects or medications or things like long QT syndrome, which are often due to electrolyte imbalances. The ECG findings seen include a regular, rapid, wide QRS complex tachycardia. As you can see, these QRS complexes are wide, but they are monomorphic, which means that they look the exact same, or they have a similar morphology throughout, right? Versus polymorphic, and we look at what that is in a second. We need to manage them quite aggressively because they have a higher risk of progressing into either ventricular fibrillation, which is not good, or death from ventricular tachycardias as well. Firstly, you need to perform Doctor's ABCD. Once you do this, you need to assess their hemodynamic stability. If they are unstable, the rule of thumb is if they're unstable, you shock them. So if they have VT with the pulse, you go for cardioversion. No pulse, defibrillation, right? If they're hemodynamically stable, you can use different classes of antiarrhythmic medications like lignocaine or flecainide. And then you start them on chronic antiarrhythmic medications to control their rhythm if you suspect a structural issue. Torsades is a type of polymorphic VT. What I mean by polymorphic is that it's quite similar in having those wide QRS complexes, but the shape of the QRS complexes themselves changes throughout. As you can see, it is nice and wide here and then gets a bit thinner and narrower and then gets wide again. And it almost is as if it's rotating around an axis. That's how it's described to be. And that's torsades in particular. One of the main risk factors for torsades includes long QT syndrome, which is often caused by electrolyte imbalances, so your hypocalcemias, kalemias, and magnesiemias, but also medications like sotalol and erythromycin. A buzzword that's quite commonly used is a young female with an eating disorder. This is because they have a poor nutritional status. They might often have these electrolyte imbalances that I mentioned. And again, you would treat them the exact same as you would a VT, with perhaps different choices of antiarrhythmic medications, but I don't think you need to know the specifics of that. Ventricular fibrillation, as Captain Holt likes to say, everything is garbage. This is pretty much your worst case arrhythmia. Causes include VT that has progressed onto VF as well as AMIs. It doesn't look like anything. You cannot interpret this, and it just looks like scribbles on a paper. If they are hemodynamically unstable, you shock them ASAP. If they are stable, which is unlikely to be the case, but still can happen, you would then again use IV antiarrhythmic medications and start them on chronic amiodarone. You can also consider an ablation surgery to ablate any parts of the ventricle that you identify as being particularly antiarrhythmic or giving rise to these VTs and your VFs. I hope that made sense. That's all the content we had on arrhythmias. If you have any questions, comment them below and I'll be sure to get to them, or you can contact me on my email or on Facebook. And as always, please look after yourself and please look after your loved ones. I'll see you guys later.